J'aimerais d'abord vous souhaiter la bienvenue pour nos 6e rendez-vous d'hématologie. Vous savez que c'est maintenant donc le 6e événement que l'on organise à but d'enseignement, un partage de connaissances pour l'oncologie. Vous savez que l'oncologie pédiatrique est souvent citée en exemple pour les progrès qui ont été réalisés sur plusieurs décades, avec aujourd'hui une amélioration qui permet d'obtenir un taux de guérison de plus de 80%. C'est un exemple parce que l'approche qui a été utilisée est une approche systématique en utilisant des protocoles de recherche et l'inclusion des patients dans des protocoles de recherche permettant de déterminer de manière très très claire les meilleurs traitements possibles et d'améliorer progressivement ses chances de guérison. Mais aujourd'hui, on en reste qu'il y a encore un enfant sur 6 atteint de cancer qui ne survivra pas à sa maladie. Plus de 70% des patients vont avoir des séquelles des traitements et aussi de leur maladie, ce qui fait que la recherche reste toujours plus absolument nécessaire et elle est incontournable. Par contre, il est évident que la recherche clinique pour des enfants qui sont déclarés en impasse thérapeutique peut soulever des questions éthiques nombreuses. De plus, les exigences régulatrices sont de plus en plus fortes et mettent une pression de plus en plus importante sur les chercheurs, mais pose aussi des défis majeurs sur l'accès aux médicaments. Alors aujourd'hui, nous tenterons d'adresser une partie de ces questions. Comme je le disais, cette activité elle s'insère dans le cadre des rendez-vous d'hématologie, donc une activité qu'on a initiée maintenant depuis 6 ans et qui fait partie des activités de notre service d'hématologie, d'oncologie et du centre de cancérologie Charles Bruno. Le terme de cette journée, je tiens à le souligner, a été décidé il y a plus qu'une année et n'a aucun lien avec un reportage que certains d'entre vous ont peut-être vu et diffusé il y a quelques semaines. Il n'a pas pour but de discuter spécifiquement certaines études, ce qui fait que nous ne penserons pas discuter de l'étude d'Éthique aujourd'hui. Il s'agit vraiment d'avoir une discussion autour des thèmes que l'on veut évoquer. Alors, aujourd'hui, on veut vous sensibiliser aux enjeux de la recherche et on a le privilège et la chance d'avoir maître Pat Sullivan, qui est fondateur des Cornes. Je vais vous le présenter dans un moment. Il est aussi un représentant de famille et de diverses associations. Et lui, il va nous discuter de l'importance de la recherche dans le domaine, de l'accès aux recherches transactionnelles et aussi de l'accès aux nouveaux traitements au Canada et les enjeux qui sont reliés. Cet après-midi, notre journée va se poursuivre en appui avec des éthiciens, des cliniciens, des infirmières en oncologie, des infirmières en soins palliatifs, qui vont nous permettre de discuter de ces différents thèmes et des différentes facettes qui sont liées aux enjeux de l'innovation thérapeutique chez les enfants déclarés en échec. Alors pour commencer la journée, je vais vous introduire Maître Pat Sullivan. Pat est un militant qui est passionné pour la cause de la lutte de le cancer pédiatrique. Pat est le cofondateur de ACORN, pour Advocacy for Canadian Childhood Oncology Research Network et le président fondateur de Team Finn Foundation. Pat s'est engagé auprès que Finn, l'un de ses jumeaux, fut diagnostiqué de rhabdomyosarcome en 2007 et que le mot incurable qui fut prononcé pour la première fois, il travaille fort pour changer cette réalité. Son souhait de changer la recherche en oncologie est issu en partie de cette dette éternelle qu'il doit à son fils Finn, décédé de la maladie, et dans le but aussi d'influencer le cours des choses pour d'autres enfants semblables à Finn. Outre ACORN, Patrick participe à plusieurs initiatives nationales et internationales. Il siège sur les conseils d'administration de Life Saving Therapies Network, de Childhood Cancer Canada, de Coast to Coast Against Cancer Foundation et de l'Alliance canadienne pour la recherche sur le cancer. Patrick préside également le groupe de travail sur l'Alliance des intervenants contre le cancer de Biocanerics et est membre d'un groupe de travail sur le cancer pédiatrique de l'American Association of Cancer Research, membre exécutif de Terry Fox Research Profile Initiative, membre du CTGG Lay Representative Committee et chef de file du St. Baldrick Stand-Up to Cancer Immunogenomics Dream Team. Donc, je pense que ça fait quand même... on va s'arrêter sur ces crédentials si je ne vous ai pas convaincu sur la valeur inestimable de Pat Sullivan. Pat est donc avocat de profession et il est spécialisé aussi en litiges corporatifs, commerciaux et de valeurs mobilières à la firme de Vancouver, Taylor Venot Sullivan. Il est fier d'être le père de 3 enfants remarquables, Baird, Sarah et Finn, et serait prêt à presque faire n'importe quoi pour le simple plaisir de pouvoir tenir à nouveau la main de son fils Finn. Alors le sujet de sa présentation aujourd'hui, c'est les patients comme partenaires, le rôle intégré des patients et de leurs familles dans les progrès de la recherche et des traitements en oncologie pédiatrique des adolescents et des jeunes adultes. Pat, it's a real pleasure and privilege to have you among us, and I'll leave you to stand.
So I want to thank you for the opportunity to present today. I will apologize. Despite growing up in Eastern Ontario, my ability to present in French has rusted over time in living in Vancouver, so I will be presenting in English today. There are 3 pieces to what I want to talk to you about today, and they're sort of distinct pieces, but they interweave somewhat. I'm going to tell you about ACORN and the history of ACORN and how it came together and some of the initiatives we're involved in on a national basis. I'm pleased to finally meet one of the fellow members of ACORN today for the first time in person, Nelson. So we have representation across the country, which I'll touch on. I'm also going to talk to you a little bit about storytelling and the importance of storytelling in presentations. And finally, and I think probably most importantly from my perspective, touch on a patient's perspective of developmental clinical trials, phase 1, phase 2 clinical trials. It's a topic I've been thinking fairly deeply about over the last month and have had an opportunity to sort of develop my thinking as I've presented on this. It's been described as relatively provocative, the way that I want to approach it. And so I welcome any and all feedback, particularly on that aspect of what resonates and what doesn't, because this is a theory I'm developing. So you are in part my guinea pigs for sort of figuring some of this stuff out. So ACORN itself stands for Advocacy for Canadian Children Oncology Research Network. Hold on. So there we go. So ACORN's mission is we are committed to advocating for Canadian researchers and clinicians as they implement the dream of curing pediatric cancer research through translational and research and effective treatment. So it's in oncology, pediatric, and AYA, so it's adults and young adolescents. It was formed in 2014. There were 3 of us that came together to create it. Nelson joined not long after that. It was formed, and I think this is an important lesson for those sort of in the medical field here. It was formed because Dr. Jim Whitlock, who heads C17, which is a sort of collection of pediatric oncology centers across the country, invited us, along with Kathy Brodeur-Robb, just to get together and talk. And talk about how advocacy could help in the Canadian scene, and out of that we formed ACORN. So it has that sort of introduction coming from the medical community and the thinking about these issues is important, because you guys have an opportunity to fire start, to create things like this if you think creatively about what that might look like. These are some of the reasons why ACORN exists. If you look in the top left-hand corner, you'll see my son Finn. Of these pictures that you're looking at, half of these kids are dead, right? Because we didn't have effective treatments for them. And doing this, what sorts of clinical trials does it allow to? So that's back to the professional thinking the problem through. And we're now, and that proposal had the support of oncologist organizations across the country. So we were, and that was because we had developed relationships, right? That was the work we had done before to say, listen, we're going in, will you support us in this? And so we had people signing off all over, because when we called them, they know who we were, and they knew the way we worked, and they could trust the way we worked. So at this point, we're running into this federal provincial sort of government barrier thing, and now we're working on that. I think we've got, without anyone ever saying this, I am comfortable that the federal government would buy in if we get provincial governments agreeing. So now we're working on that aspect of it. So that's that. The bioethics white paper came from interactions within the science. And so this was Antonia, who sits on OCREB, which is the Ontario Cancer Research Ethics Board, as a lay rep. So she could see the ethics process from within, and she's very thoughtful. And so a first draft is completed, and we're just trying to figure out where we place that and where we move that forward next. So we'd love feedback on that. Pan-Canadian Research Ethics Board. So we have heard again and again the frustration. So in Quebec you have seen, and maybe there's frustration, maybe there's excitement about it, but the sort of forced integration of ethics review. In the context of profile, we're trying to, this precision medicine national trial, we're trying to have national clinical trials. Just getting profile approved means we have to go to 16 different REBs, right? So ACORN has been meeting with OCREB, Ontario Cancer Research Ethics Board, CTO, Clinical Trials Ontario, MyCERN, which is a general group, about once a quarter to say, how can we create a pilot in the pediatric oncology space? Again, problem is big enough, problem is small enough. Everyone talks about wanting to do it. How do we just go forward and start doing it and building a coalition? So they're going to be writing a paper on this that's going to be published. We're considering partnering with other provinces because we don't want to start with 10 because that's going to be too hard, but how do we start with a few and then build our framework up for there? So I describe myself as patiently impatient, right? I'd like to see this happen now. I think it should happen now. It's not going to happen now. But if we have the vision of where we want to get, we start thinking about strategy and tactics of how we get there. So that's what this is all about. I'm also working myself on a paper in the context of one of the stand-up teams I'm in. So the other patient advocate, her daughter died of ependymoma. Resected the tumor, but then it came back, and there were no clinical trials available. And I had a very powerful hour-long conversation of her journey through the medical system and what that meant. And what I want to do is say, here's what's happening over this timeline. Let's superimpose what's happening in an REB, assuming there had been a clinical trial available, and how much time she was spending versus when you've got 4 different sites, how much time it would take. And you're going to see that timeline of the REB approval taking way longer than Jesse's life, right, from the time of diagnosis to after. And I don't even know if I have to draw the conclusion, or it will be so natural to see this needs to be improved. And this is not a shot at any REB. They're critically important. It is very important that we have that in the process. We don't need it 16 times, though, right? That's my contention. And there's ways to speed it up. Meetings with Health Canada. So following the meeting with the Federal Minister of Health in April, we had a meeting with several people from Health Canada, about a dozen employees. There was 5 of us from ACORN that were there. The purpose of that meeting from my perspective was twofold. I want to build a relationship and a sense of trust with Health Canada that we're there to work with them. We're not there to blame them. We're not there to accuse them of anything. They are doing hard work trying to do the right thing. We want to understand what their challenges are so we can help make the whole process better and we can get things to kids faster. So a big part of that meeting was just to try and help develop that relationship of trust, and it's going to take a long time, right? The culture is nervous about interacting with advocates. I should say our second proposal to the Federal Minister of Health was a working group or a secretariat with the Ministry of Health of a collaboration between patients and advocates. How do we deal with these various issues over time? How do we keep coming into a room so that we're having this honest dialogue about solutions, where I understand your pressures that are beyond just the pediatric oncology space, and you understand mine. And I want them to start thinking of pediatric oncology and AYA oncology as a regulatory sandbox where we can think innovatively about solutions together. So the second objective, and this was working with CIHR, the Canadian Institutes of Health Research, again, relationships we've developed over time. They are hosting an in-camera meeting in December where it's confidential, where we have representatives of Health Canada, advocate representatives, a number of oncologists from across the country, where we're going to be addressing some issues that we can try and tackle together in a confidential sort of way. And I see this as a starting point to hopefully make some meaningful difference. One of the issues that we will be discussing at this meeting is Accelerate. I had not heard of Accelerate 2 months ago. Health Canada put this on the table as a stalking horse that we could talk about. Accelerate is a European-driven initiative that is a collective of patient advocates, clinicians, scientists, advocates, industry, and regulators, all in the same room discussing pediatric oncology, right? And a couple of years ago, the US joined. So if you look at their steering committee, it's 16 people. It's 4 from industry, 4 from the regulators, 4 from academic and clinicians, and 4 from patient groups. And having heard of it, I've gone out and effectively done a mini needs analysis or a mini analysis of talking to people within Accelerate about what works, what doesn't. And so what I'd like to see at a minimum is Acorn join Accelerate and be a Canadian voice as part of this international consortium, because the reality of, if you're looking at industry development anywhere, including the pediatric space, it's international, and we have to be part of the international dialogue. And if Health Canada will come along, that would be a fabulous win for me, so they can be in that room and hear what the other regulators are doing and hear what industry is doing. I'd also like to see us develop some equivalent of that in Canada, right? Some node that feeds in. I don't want to recreate it, but how do we bring all those groups together? So we don't have an industry at this meeting in December. I'd like to see them there, because we're starting to see industry more and more in our space where we haven't seen them historically. How do we encourage them to be there more, right? There are fabulous legislative approaches being used in the US and Europe. None of that is here. What's a Canadian model that we can do? How can we encourage pharma to be here? And I'm going to pause now to tell you a story. So this is the second part of my presentation. That was about Acorn, sort of where we are, what we're doing. When I sent Patrick Cossette sort of what I would talk about, I said I would talk about stories. So this is a bit of an aside, and this is for your continuing education credits as much as anything. And I'd like to think you're going to get value for your dollar in a second. So this picture, if you look, all of those kids are focused on the woman telling the story. They're not distracted. They're not doing anything else. They're not on a screen. They're engaged in that story, right? I have had the pleasure of going to a number of different scientific conferences where there are deep biological talks. There are accessible talks. As I said, I have a grade 11 science degree. I've educated myself over time, and I've always said if I get to the third slide and I still understand it, I'm happy, right? What I've discovered over time is my understanding, or my lack of understanding, is not just my fault. A lot of the presentations suck, I'm sorry to say, right? They don't move people, they don't get recalled, they're not in the short or long-term memory, they don't involve the audience in any way, they don't influence the audience. And the people walk out and they have no idea what was just said, but they got a lot of emails dealt with, right? So if you want to do a good presentation, you have to recognize that there is a science of storytelling. Right. And I've got a longer deck that sort of talks about this, and there's some wonderful literature on this, and there's some great podcasts if you're that type of person. And Kendall Haven is someone in particular that I've been following. But I'm going to tell you an aspect of this to make a point. So a lot of the presentations I attend to are data heavy. So this is an example from a book by Kendall Haven. So I encourage you all to read this and try and make some sense of it, right? And I'll give you just a minute or so just to see how far people get. Okay, everyone understand what's going on? This is me at a data-driven presentation. Okay? The problem with data is like a plot in a story. When all you have is plot, and the plot is just a series of events, it's frustrating and meaningless, right? You need your data when you go and present at science. Data is king in the scientific world, but the data should support your story. It should not be your story, right? Data alone is not enough. Read that. Sally hates the woman who moved in next door, motive, and wants to drive her out, goal. Now read it. Right? There are simple but highly effective ways you can do a much better job of presenting if you think that you're there to tell a story. The currency of stories is attention. You want people to pay attention to you, and you want them to leave having taken something from what you say. There are a series of other tips that I won't go into, but I think this is hopefully a starting point for some of you to start thinking about this in a different way. So on to the provocative portion of what I had to, what I'll have to say, or at least some have described it that way. Oh. So I can't tell if the screen is, oh, it is. Okay, so phase 1 clinical trials. We know, and I understand from an ACORN perspective, that phase 1 are really dose-finding studies, right? What's the maximum tolerated dose? Is it 3x3? Is it rolling 6? What's our approach, right? And then you have phase 2 clinical trials, efficacy studies. Does it work? What's the response rate? What are survival outcomes? It's a way of collecting additional data, right? So that's phase 1 and phase 2. We also have, and this is something I became aware of after I gave a version of this talk the first time, having watched an ethicist, this thing that drives me crazy, the therapeutic misconception, that the belief that the purpose of a clinical trial is to benefit the individual patient rather than to gather data it's really about science. It's not at all about the patient, right? That's how I read the sort of therapeutic misconception. And this is, from the National Bioethics Advisory Commission. The problem that I have with that approach is I don't know if any of you are fans of behavioral economics, but this is like the classic econ of classic economics versus behavioral economics. No one thinks that way. No one reacts that way. The people in this room are not doing clinical trials for science. They're doing them in a scientific way, right? And the scientific way is critically important, but that's not why you're doing it. Why you're doing it, I think, takes us back in time, is where I want to start. So this is Dana-Farber. How many of you have read The Emperor of All Maladies? Okay, those who haven't, I recommend highly that you do. So this is a biography of cancer. The biography of cancer is this Pulitzer Prize winning romp into sort of the history of cancer. It is dedicated to a 3-year-old by the name of Robert Sandler. Robert Sandler was a twin. My son Finn is a twin. Robert Sandler died at the age of 3. My son Finn died at the age of 3. So this meant a lot that he dedicated to Robert. And I had a chance to see Siddhartha Mukherjee speak. And so I asked why. Why that story? Because he has lots of stories. And he said, because Robert Sandler is the patient zero of clinical trials. Farber, in 1947, at the end of the year, 70 years ago, gave Robert antifolates. He wasn't walking at the time. He was bleeding profusely. His tumors melted away. His blasts sort of melted away. He started running again. He started playing with his brother again. Unfortunately, it lasted for about 3 months. And then Robert died. And if you evaluated that trial, there was lots of partial responses. Or lots of responses, they just weren't sustained. I measure that trial as a success. Others would say it's a failure. It depends on how you look at it. But the reality is that approach is what led to Frierick and Fry and Holland doing triplicate chemotherapy down the road. That's how we learn. But he didn't do that. And when Siddhartha Mukherjee said he's the patient zero of clinical trials, Robert Sandler wasn't in a clinical trial. Right? Dana-Farber had a theory that this could work, and he tried it. And it did work for a time. So I want to tell you about this from my perspective. So this is Finn and his twin brother Baird. When Finn was diagnosed, rhabdomyosarcoma, we were told he had a 70% chance of survival. So as a parent, that means nothing to me. I just want to know what you need to do to fix him, and let's get at it. How do we get rid of the cancer? How do we save Finn? And how do we move on with our lives beyond cancer? So you're starting with uncertainty right from the outset. When Finn's tumors didn't shrink or debulk the way that everyone hoped through chemo, the surgeon said, okay, you have to do radiation first. And the radiation oncologist said, okay, you have to do surgery first. And then there had to be a debate between them of who was going to go first. And I'm a witness to that debate. That is uncertainty. We were the first family from BC to make it to MGH for proton beam therapy. I spent 3 weeks back and forth, uncertain if we were going to get there or not. You spend all of your life as a parent uncertain when you're in an oncology diagnosis. That follow-up MRI, what's going to turn up? That's uncertain, right? So medicine is a science of uncertainty and an art of possibility. When Finn relapsed in 2008, I don't know how many of you have seen the Pfister slide, but the 3-year survival curve for relapsed rhabdomyosarcoma is 0, right? It was metastatic. It was in his lymph nodes. We had a pretty good understanding of what that meant at that point. And he was in a tremendous amount of pain. I could see his tumors growing, right? They were in various locations. And so we were exploring ways not to cure Finn, but to help him. How could we do that? So this is something we tried, palliative radiation. We tried it because we thought it might help. It had a cost for us because it meant anesthesia, and we were giving away time, and so we had to measure that cost. And it didn't work. His tumors were radiation resistant, and so we stopped after 4 days. If you had bundled that into a clinical trial, my decision-making matrix would not have been different. I would have made the same decisions on the same basis. Wasn't the clinical trial might have, if they had any at the time, might have given me access to something else, but this wasn't, right? Then we go to later that same month, an interventional radiation therapist worked very tirelessly to find us something that would work. So cryotherapy. They explored cryotherapy, heat ablation, chemicals directly in his tumor. Heat ablation, the feeling was that could kill him given the size and location of his tumor. Chemicals were a worry because they would leak and cause tremendous pain. Right? Cryotherapy seemed like it had a shot. So we drove 7 hours to Spokane with Finn lying in the back of the van with my wife because he couldn't sit anymore. Right? And after that, he did this because I saw his tumor shrink. Right? He ran at this party with my wife, and my 6-year-old or 5-year-old daughter at the time ran around to all her friends saying, "Finn is running, Finn is running. Did you see?" He got to do this with his twin brother. Right? I got to walk with him to the last full moon. He was here with us. Right? Something I try and do every month since. So for me, measuring, if you had said cryotherapy was in a clinical trial, I would have went through the same analysis. I would have been evaluating it from what benefit can it get Finn. I will never think of it as a phase 1, phase 2 clinical trial, despite understanding what that is. You will never convince, in my view, patients to think of it that way, and I don't think clinicians and researchers think of them that way. So I think it's a myth that prevents us from moving forward in the appropriate way. So in between talks, again, I heard this medical ethicist speak, and it was a fabulous talk. I really enjoyed it. And I got up after his talk, and he talked about sort of risks, benefits, and I said, I think maybe you're missing some of the benefits. Have you talked to parents about sort of what the benefits are? And he directed me to this paper, which is fascinating to me. It looks at parents whose children have died and what their view of what they would have done at the time of diagnosis, what their care goal was, at the time they realized their child was going to die, and then later what they think. And what's really interesting to me is despite knowing they're going to die, a sizable portion were still looking for curative intent at that point, but how that changed and went down after the fact. But what really went up, equally with curative intent was, I want to decrease suffering. And that went way up after the fact, right? So he presented this decision-making matrix, but he didn't call it in a world of uncertainty. That's me. What are your goals of care? What are your risks? What are your benefits? What alternatives are you foregoing by going through a clinical trial? And what are the research goals, right? That's a decision-making matrix that can apply right from the start. It's your degree of uncertainty that changes, your reasons for deciding something that change. But to say it's just research does a disservice, and it causes tremendous disadvantages. So I think we have to change a paradigm. We have to stop confusing how we do clinical trials. We do them through phase 1, we do them through phase 2, we do them with REB approval, with why we do clinical trials. We need to focus first on why, because that influences how we think about how. Confusing how with why leads to compartmentalization. So we've got this false paradigm of treatments here, experiments are here, and there is a bridge and that never the twain shall meet. And that allows us to say we don't allow patients to travel for phase 1, phase 2 because it's experimental, and therefore it fits in that box. Versus that trial is way too uncertain, so maybe we won't allow that one. That one's got way better evidence. Maybe we'll allow travel for that one. It doesn't allow a nuanced view when we look at how with why. It puts us in straitjackets in our language and how we approach things, right? We saw the number one thing that came up in our needs analysis was the regulatory burden. This picture of the blood clot developing over time, that's how I think we're dealing with developmental clinical trials. Because we focus on how, we build a how on top of a how and a how on top of a how till we've choked off the supply to clinical trials. So if we start thinking about why, it will allow us to push through and think about how we approach these things differently. It impedes access to treatment, as I've just touched on, and it creates artificial barriers that don't need to exist. There are challenges that we've recognized in clinical trials. If we're going to change the paradigm, we need to recognize those challenges. They aren't just going to disappear because we have why at the forefront. So I think there's an opportunity to do all of that. And I think the opportunity, in my view, is here. We have a national precision medicine platform. It is across various borders. It is the intervention in risks are typically around a biopsy or potentially foregoing other things. We are going to get even smaller subsets of patients on a molecular basis. It will create an opportunity for us to think about clinical trials. The reason we're doing profile is because we're focused on the why. We want to give those patients access to something different. It's why you're doing triceps. It's why this all fits in. What I like about this is the national basis, which gives us a national voice, and it's one of the topics that will be discussed with Health Canada, is how can we innovate around clinical trials? How can we think about doing phase 1, phase 2, allowing it to be approved, and then doing phase 4 real-world data after the fact as a way to get around this whole off-label problem that's blown up, as an example. So, again, and most importantly, we need to design with why in mind. We need to go back to what are patients trying to get at. And so if you think that a big goal is reducing suffering, and that's as important as curative, although curative is always going to be high. But if you think your curative is, we're on the start, it's likely not to cure now, but what we learn later will cure later. You may design your trial so it's got less suffering involved and move the science forward slowly if you're thinking about the patient and what the patient actually wants. Right? It could actually make the trial less aggressive rather than more if you think about the why. And sorry, I told them I would be shorter than I thought, and I was longer than I thought. So that's sort of my wrap-up for me. So that's a sort of 3 different, very divergent topic areas. But if we have time, I'm happy to take questions about any of that.
First, I'd like to thank Patrick. And if there is one of the reasons why we strongly believe here at Sainte-Justine in patient partners, here is a reason why, right? I think, in my view, we need to change our perspective, and I think Patrick really illustrated it very well. And thank you for doing this. Any questions in the audience?
Thank you a lot for your presentation. Hello. Thank you a lot for your presentation. I found it very moving and very interesting. My question is regarding day-to-day. You talked a lot about systemic change. There's a lot of people here that work with patients day-to-day, nurses, physiotherapists. Do you have any input on how we can help families manage with their going through phase 1 and phase 2 trials?
So I think that slide I had with those 5 sort of reference point, what are the goals of care? My sense is the oncology community could do a better job on the goals of care point. You're going to have different patients with different levels of sophistication and different goals that they have in mind. And you're going to have patients that no matter what are just going to keep fighting and will not accept that their child is going to die. And so I think you have to have frank conversations with them in a caring, very caring way. But patients are going to feel that way, and you're going to have to sort of recognize that. I think there are other patients that will be more accepting of the likelihood of something. And so if you're talking about clinical trials, don't be paternalistic, right? Don't decide for them is something I would strongly encourage. Having those discussions and those hard discussions isn't easy. I mean, it wasn't easy for our oncologist to tell us that Finn had relapsed because he knew what that meant. It wasn't easy for the people at Canuck Place to talk to us about death. It wasn't easy for me to explain to my 6-year-old daughter that her brother was dying, right? But just because it's not easy doesn't mean it's not important. So how you do that well is a learned skill, but it's also thinking, that slide I presented was eye-opening to me because that's certainly how I felt in terms of wanting to reduce Finn's suffering and to see that reflected. I don't think our trials are designed with that in mind, though, a lot of the time. So I think get input from them, make sure when they're in it, just be with them wherever they are in it. And at some respectful distance in the future, if their child dies, if their child lives, if they're a black swan on some clinical trial, consider whether you reach out to them to get more feedback about what that experience was like to help educate yourself. So, and if you can do that systemically in some way, I think that would be of value.
Can you tell us how you identify or select or recruit the parents and the patients that you can be assured that they will stay in a co-building perspective rather than in confronting advocacy perspective, and that you train them, you maintain
that's a really, really good question and a really important one. In a presentation I did yesterday, I touched more on that. There is 2 really important answers to your question, or 3 really. So identifying them is the same way you would find an electrician or a mechanic. You ask around and find out who might be suitable for doing something like this. Another answer to your question is you got to find horses for courses. So I had a picture up in my slide deck yesterday of a bunch of Shetland ponies racing, right? Don't bring a Shetland pony to the Kentucky Derby. It's not going to work. So you have to find the patients who, they don't have to be scientifically skilled, but they have to have a willingness to learn the science. They have to have a desire for doing that. you have to be careful. And then there's the personality mix, right? There are some advocates I see who are one-issue advocates. So I think it's like a job interview. How do you find someone who's amenable to that job? And then the training. There's lots of training things out there. Training becomes important. If they don't have the scientific aptitude, how can you help develop that over time, right? And there's training courses, there's popular science they can read, or you figure out, here's a role that's really good for them. Like I'm a securities and commercial litigator, don't bring me a family law case, right? So what fits with their sort of skill set?
S'il n'y a pas d'autres questions, je pense qu'on va arrêter la session aujourd'hui.